Hello everyone, my name is Naomi Valdez and today I want to talk to you about my reflection and perspective on the round this week. And we're going to start with the first question, where are the main points of these ratings? All these three articles are written non-communicable disease like NCDs, such as diabetes, cardiovascular disease, and obesity, present a growing health concern from migrants population, and these risks are not evenly distributed. An article by Engelman and Van der Bonn showed that migrants' NCD risk is shaped by a combination of genetic predispositions and the lifestyle change post-migration, and reduce the access to a quality care in host countries. And this one, for instance, the cardiovascular disease among the African immigrants are markedly had and worsened over time, and while cancer patterns tend to reflect environmental infection exposures. Another thing is showing the Montesi article, and this one showing how diabetes disproportionately affect the migrants and ethnic minorities across the world. And in particular, even in countries with universal health care, these groups receive the lower standards of care due to systemic biases, cultural barriers, and reduced health utilization. And they also highlight the early onset and greater severity of complications like retinopathy among migrants, often stemming from the late diagnosis and the poor community of care. And for last instance, in the article by Fran and Cunningham, offered a longitudinal perspective of the review the studies that show clear positive correlation between the duration of the use residence and BMI increase. That in most immigrants arrived healthier than the native-born population, but this advantage fades over the time with the obesity rates of the superseding those of this native after the 10 or 15 years of living in the USA. And this will be confirmed the lifestyle acculturation, especially diet and physical inactivity, that along with the socioeconomic pressure and culture and structural exclusion, contribute to the weight and gain and related disease risk. Continue with the second question. Was there anything unclear or confusing to you and why? Something that actually I think is the aspect that raised the question for me was ambiguities surrounding the role of the genetics versus environment. And the Angelman and Bondenbarn discuss ethnic variations in cardiovascular outcomes, such as higher stroke rates in the sub in Saharan African migrants. And this is unclear how much of this genetically driven versus the socially constructed the total spectrum inequality. And they mentioned epigenetic interactions, but without the concrete examples. And I found myself wondering how much weight we should guide to biology by versus the lifestyle and structural determinants. And similar in the Montesi article, the ethnic conversation where the migrants have gradually aligns with the host populations, and while conceptually interesting, I found the timeline and the mechanism is really big. And do the migrants really adapt the health patterns of this host country, or they have developed every risk to the living in the marginalized environment? It's a conversation inevitable, preventable through the targeted policy and community interventions. And for the last one in the also Frank Cunningham article, also let me question in the threshold effect of the weight gain after the 10 years living in the US with residents. And in this review, that MBMI increased the level after the decade, but it's unclear whether this is due to behavioral adaptation or biological planetarian or data limitations. And I will have like more discussion of protective factors of successful intervention during this transition period, and this uncertainty made me reflect on the need for more nuanced and context-specific research. Well, now with the third question, what was new to you and did it change how you think or perceive the things? One of the most eye-opening ideas for me was the erosion of the so-called healthy migrant effect over the time. And I had previously believed that migrants remain healthier than native-born populations due to stronger family structures or lower initial disease prevalence. But however, in the article by Osa Frank Cunningham, challenges the idea by showing that the health advantage often diminishes significantly with longer residence, especially in the USA. And I was not exactly surprised to learn that prevalence of the obesity often exists that US born individuals after a decade. But I really feel like, okay, this is not common or something actually I expect. And particularly among those who arrived at a young age, like kids. And another powerful sheet of perspective came from the article by Mondesi is the who highlight how even in countries with a strong healthcare systems, migrants consistently receive substandard care. And that idea that universal access does not guarantee the universal equity was recently, and I have assumed that if immigrants have the legal right to access the service like people have residents, disparities will be minimal. And instead, I now understand how cultural dissonance, low the healthcare literacy, and the systemic racist play enormous roles in the limiting actual access and quality. And the Anjuman and Vandenborn helped me realize that entities among migrants are not just about lifestyle change, but are deeply influenced by the structural determinants like housing, employment, and discrimination. And this shifted my thinking from viewing that this is like diabetes and obesity are primarily behavioral issues to saying that indicators of systemic inequity. And as a future physician, this refers at me like the clinical decision must be brought in empathy, cultural competence, and advocacy for broader challenge because it's something that actually is not only fair. It's most like it's things about the races or about the inequalities just from the country you come in and and even if you have the residence actually it was something new to me. Well, and continue with the first question. Was there anything you would like to explore further or learn more about and why? I am particularly interested in learning more about how public health systems can be prevent the NCD progression among the migrants in the early years after the arrival. And the article by Osa, Frank, and Cunningham mentions that weight gain often begins in the first decade, and yet very few targeted interventions seems to exist from recent migrants. And I like to explore what are culturally relevant programs like community walking groups or nutrition education and the community or mobile screening could be implemented to prevent this early deterioration in migrants citizens in USA. And additionally, Montesi article made me curious about how we can address the gap in the diabetes care, and they describe how many migrants are diagnosed late and receive the lower quality treatment, even in countries with the programs of universal care. And would love to study models of integrated care that have a work in the other contexts and such a community health workers in many migrant neighborhoods or clinicals that employ bilingual staff and offer dietary counsel and adaptive cultural food practices. And now, finally, with the Anjuman and Vanderbilt in this case, the need for better data disintegration, I like to delve deeper into how epidemiological data can be collected in more inclusive and representative ways. And many national data sets still lump immigrants into the broad racial or ethnic categories, and which hides the important difference between the subgroups and learning how to ethnically and ethically design research that reflects the real diversity will improve not only on the knowledge base, but also the policies that arise from it. Well, and now but not least, the last question got us at least one specific example of an aspect or experience in your personal or professional life that relate with the main topic. Well, and during one of my relations and the primary care clinic with the school, we have patient and I met with a middle-aged woman from the Central America who had recently been diagnosed with the diabetes type 2, and she had been living in this country like 3 months, but she actually arrived from the US. Then she was migrant and she living right like in I think like 12 years. And although she had a legal residency and health insurance, and she had at least taking care for years, do she say like the language barriers? Like she's talking Spanish, but and in United States, uh, care some misunderstandings with the system in the United States. And this time we saw her, she was already experienced like symptoms with neuropathy, and her case brought to life exactly what the Montesi discuss describes: the late diagnosis and complex complication and poor continued care in migrant patients. Uh, and what stood of the most of me was her dietary habits had changed dramatically since she moved into the US. And she told us that fresh produce and was more expensive and harder to find. And she was working to just avoid the little time to cook and to put some attention in her alimentation. And she have adopted a highly processed carbohydrate heavy diet because it was affordable and convenient. In we were be honest, in the United States, this is too cheaper. So it's that reflects the trends online and in the article by Elsa, and how the migrants' lifestyle change are not necessarily voluntary. A lot of times is shaped by the socioeconomic realities and the structural barriers to have like a good job with a good salary and and have the living in the United States is something that actually expensive, and this experience left me a deep impression of me, and it taught me to that addressing the NCDs in migrant population requires more than just descriptions. It demands time and trust in system that can run for real life constraints, and I've seen become more aware of the importance of asking about housing, food access, and work schedules, and every patient encounter, especially with this type of patient that are migrants from the central or even in Mexico that have to migrate in to US, and made me realize how they easily this type of person have to live in with these conditions and can fall throughout the cracks when medicine forgets the person behind the disease.